There they are. The ambulance doors burst open. A man is being rushed in. And guess what? You're the doctor on call. Let's get to it.
You glance at the chart. A few words just leap off the page. Sudden onset of severe chest pain. This wasn't something that built up over time. No, this was like a switch being flipped. A sudden, violent event inside his chest.
He's your patient now, and every decision, every single thought you have in the next few minutes could mean the difference between him going home or not. The race has begun.
Okay, let's get this story straight. Right now, every single detail is a potential clue to solving this puzzle.
So, what do we know? He's a 42-year-old basketball coach. The pain he describes is a ripping or tearing feeling. And here's the kicker. The giant red flag flapping in your face, they gave him 3 doses of nitroglycerin in the ambulance, and it did absolutely nothing. Nitroglycerin is for a blockage, a clog in the pipes. If it didn't work, we might not be dealing with a clog at all. This is probably not your textbook heart attack.
You look at the patient. First thing you notice is his build. He's tall, with unusually long arms and legs, and he's diaphoretic, just drenched in sweat, and you can see the pain on his face. He is clearly in serious distress. Even his body type could be a clue here.
All right, enough of the story. Let's get to the physical exam. We need some hard data, some numbers.
First up, heart rate 118 beats per minute. That's way too fast. He's tachycardic. His body is in full-blown crisis mode and his heart is working overtime.
You take his blood pressure on his right arm. It's 156/100. It's high, sure, but he has a history of hypertension, so that's not totally out of left field.
But then you take the pressure in his left arm, and it's 188/94. Whoa, that is a huge difference.
Let's be clear, a 32-point difference in blood pressure between arms is not normal. It's a massive, glaring sign that something is physically blocking or obstructing blood flow to one side of his body.
And this right here is how you start to tell this apart from a regular heart attack. Heart attack pain usually builds up. This guy's pain was at a 10 out of 10 the second it started. And like we saw, it laughed at the nitroglycerin. Why? Because this isn't a simple plumbing clog. This is a catastrophic structural failure.
And the clues just keep piling up. You notice he has pectus excavatum, which is a caved-in chest, something that's often linked to disorders that can weaken the aorta. You listen to his heart and you hear a new murmur, which tells you the aortic valve itself might have been damaged. And then the chest x-ray pops up on the screen, a widened mediastinum. The area around his heart is visibly swollen.
All of these external signs are pointing to one terrifying place. So what is actually happening inside his aorta right now? Let's peel back the layers.
It's called an aortic dissection. We're not talking about a blockage. We're talking about a tear in the inner lining of the aorta, the main highway for blood in your body. And now, the massive force of his own blood pressure is burrowing into the wall of that artery, splitting it apart and creating a new, fake channel where blood should not be.
So here's how this nightmare unfolds. It starts with one tiny rip in that inner wall. High-pressure blood then forces its way into that tear. From there, it just carves out a new path inside the wall of the aorta, creating that false lumen. And this tear can keep going, unzipping down the length of the aorta, choking off blood flow to vital organs as it goes.
And this process sets off a terrifying domino effect. Look at this chart. It explains everything we're seeing. That new heart murmur, that's aortic regurgitation, caused by the dissection tearing up the root of the aorta. The different blood pressures in his arms, that's because the dissection flap is blocking a branch artery. And if this keeps going, he could have a stroke, his organs could fail, or the aorta could rupture completely, which is almost always fatal.
We have the history, we have the physical exam, we know the science. Let's put all the pieces together and name this thing. Think about it. The sudden tearing pain, that was the initial rip. The wacky blood pressure difference, that's the flap blocking flow. The new murmur, that's a damaged valve. And the wide shadow on the x-ray, that's the aorta, literally swelling with trapped blood. Every single clue points in the exact same direction.
The diagnosis is crystal clear: aortic dissection. And given his build, that tall frame and caved-in chest, you have to be highly suspicious of an underlying disorder like Marfan syndrome, which is famous for causing weakness in the aorta.
Okay, we've got the diagnosis. But in an ER, knowing what's wrong is just the beginning. Now we have to move, and we have to move fast.
So the ball's in your court. What is your absolute next step? What do you do right now?
Okay, 2 things need to happen immediately, and I mean immediately. 1, we have to get his blood pressure and heart rate down. We have to slam the brakes on. Every single heartbeat is putting more stress on that tear, making it worse. We'll hit him with an IV beta blocker to take that pressure off. 2, we need emergency imaging. Get him to a CT scanner, stat. We need to confirm this and see exactly how far the damage goes.
And this really gets to the heart of it. Aortic dissection looks so much like a heart attack, but the treatments are polar opposites. If you had mistaken this and given him standard heart attack drugs, like blood thinners, you would have made him bleed out uncontrollably. It would have been a fatal mistake. It's a chilling reminder that in this race against time, getting the diagnosis right isn't just important, it's everything.